Good evening, everyone, and thank you for joining us tonight for July Chris O'Brien Lifehouse CPD series medical update on pain management. My name is Lydia Koenig. I am CPD Program Officer here at Central and Eastern Sydney PHN, and also working with me tonight, Sue Moxon, Member Support and CPD Program Officer. Tonight's session, I would like to start by acknowledging traditional custodians and sovereign people of the land across which we work and meet tonight. I would like to acknowledge and pay my respect to elders past, present and emerging, an important role that they've been playing and continue playing for Aboriginal communities. I would like to offer my respect to Aboriginal and Torres Strait Islander people joining us tonight.
Hi everyone, thanks for letting me gatecrash your meeting tonight. I won't take up too much time. I'm the manager of the Practice Support and Development team at CESPN. And I'm here to talk about another survey, which I'm sure that you all don't really want to do another survey, but this one's really important for our region. So I'm begging. So I guess, as you know, as you probably know, GP Synergy has been the training organisation for GP registrars over the past years. And you would know that it's not the case now that RACGP and ACRIL have taken on this role. The Commonwealth Department have engaged PHNs to help provide independent evidence-based recommendations to inform the geographic distribution and placement of registrars so as to meet the community's current and future GP workforce needs. We have a survey, as I mentioned, and this has been developed by ACT PHN, who is the lead PHN for this project in New South Wales. It's an easy one to fill in. You can be a GP registrar, supervisor, a practice manager, a nurse in general practice. It's to sort of gather information around our region and our experiences in that. So there will be a QR code that you can do it through your phone or a link on your computer, which is pretty easy. So this is a very widespread of health professionals, means that we can gain a good insight into what GP workforce and any issues. Your insights and expertise will help in understanding the enablers and what helps and supports the workforce, and also any barriers that might come up. We would also be interested in any possible solutions to current and emerging workforce issues and shortages that you might have. I'm sure you all have lots of thoughts on this out there. We as a PHN, we don't have a say in the placement of registrars in general practices, but the more information and feedback that you can give us will help us inform the colleges of any workforce needs. We're also offering to do some consultations either in a group or one-on-one or face-to-face, or can do over the phone after filling in the survey, and there's an opportunity to put your details in that. We can also do this consultation even through an online form, so you can sort of put down your thoughts. And this is to gather further information on your experiences as a GP and or GP supervisor. If you would like to do this, please email us at the practice support email on the sheet, or give me a call. I'm happy to chat with you or come out and visit to discuss anything further. So that's really it. I'll ask Lydia to send out the survey link and QR code and information. There'll be a brochure that goes along with this. A little bit more about the project that's happening around this. This will be ongoing. So please have a think about filling it in. It's really important for our region, and we want to try and offer and feedback as much information, and whether, it's good, bad, your thoughts and experiences as GPs out there in general practice. It'd be really great if you can do this. It closes on the 30th of July, so we'll send it out for you after the event. And thank you so much for giving me your time tonight.
I think this will be a really interesting update tonight. The presentation will go for an hour, maybe a little bit longer, and then we should have some time for questions at the end. So if you just put your questions in the Q&A box at the top of the screen, then we will get to them at the end. Thanks, Dr. Yu.
Thanks, Dr. Stewart, for the kind introduction and to facilitate this session. And also thank you to Lydia and the team to organize this CPD program. I just look at your program. I mean, it's so exciting that, you know, every day or every other day you have so many educational programs. So thank you to everyone who, you know, that has logged in tonight, which you know, was taking your time out from your family to join this educational program. So Claire was saying that this is going to be a 60 to 70 minutes of presentation. You know, I'll try to cover as much you know, pain management updates as possible, but there's, you know, pain management is so wide. You know, there are issues that I like to pinpoint, especially the area of management that I'm an expert in. So, you know, this is kind of just a learning outcomes that I put up. By the end of this activity, you'll be able to manage all the pain patient in a day-to-day clinical practice, order diagnostic tests, and refer to various specialists for management opinions. But it's not always the case for chronic pain patient, because chronic pain, if a lot of my patients have suffered pain for more than 6 months, you know, some 2 to 3 years, and some over 10 years, and they're very complex. So hopefully we can cover, you know, I can showcase some of the patients that I've been able to manage over the last 10 years with complex pain history. I think before today, Lydia has sent out some, you know, some cases with quiz. So I'm just going to go through, you know, the quiz number 1 again, 73-year-old man. I mean, we're going to discuss management of this case later on. So, but if you want to share your feedback and management plan, please put in the chat. So he's been suffering from lower back pain for 15 years, has had 5 lumbar spinal surgery, started in 2018 with a fusion at L5S1, but because of ongoing pain, he had an extension fusion, laminectomy L3-4, L4-5, and then an extension fusion from L4 to S1. And then, you know, 5 years later, because of ongoing pain, he had fusion up to T12 to S1. And because of ongoing pain, 2 years later, you can see now he's had 9 levels of extension from T10 to S1. And when I saw him 18 months ago, he was already on Lyrica and Norspan patches. So what else, you know, what are the next treatment option for this patient? So, you know, think about, you know, your management option. We're going to go through this case afterward. Second case, it's a gentleman who is not too old, 53-year-old, but has been complaining of lower back pain for close to 20 years, had also suffered from a motor vehicle accident in 2012 and had increased back pain and leg pain. But when we did an MRI of his lumbar spine, there was only mild degeneration. So when about 9 years ago, he was starting to take a lot of opioids medication, OxyContin, 80 milligram in the morning, 40 at night, plus immediate release of Oxynorm, 10 milligram 2 to 3 times a day. But 4 years later, I went through all his past history. 4 years later, when he was seeing another pain specialist, his opioids went up to 120 milligram BD. And he's taking oxycodone. Usually now he's gone up to Oxynorm 20 milligram. So he takes 2 Oxynorm 20 milligram, 40 milligram twice a day. So he is taking a lot of opioid medication. So his oral morphine equivalent per day is around the 400 to 450 milligram a day. So again, this is a complex case, and how do we manage this case? I'll go into this case again later on. So I just want to give you, you know, a comprehensive introduction about how we manage our chronic pain patients. So each of the patient, if you refer to us, you know, we look at the biomedical issue. Let's say they have lower back pain, we'll look at their spine, anything, you know, related to lumbar spine, but we'll also look at the physical, their psychological status, and social functioning. So chronic pain patient may suffer from dysfunction from physical, emotional, and social. So this is the 5 pillars of pain management. Pharmacological treatment, like analgesic medication, is only one of the 5 pillars that we use. a lot of times on the first consultation is patient education. Sometimes the patient will present with widespread body pain and had a lot of surgery. Sometimes we have to set an expectation with patient that, you know, it's not going to be easy that we're going to get rid of the pain. So we have to, you know, let the patient know the expectation is to help them to reduce the pain, you know, between 30 to 50%, but then look at how we can improve their quality of life by improving their physical function and improving their mental health. And we also advocate some minimal invasive procedure injection to help reduce the pain and so that they can get back and increase their exercise regime, improving their physical function. So I work in a multidisciplinary team with 7 other pain specialists. So we're across, you know, in the east and south of Sydney. Being a pain specialist, we have to, it's our second medical specialist qualification. Some of us are anesthetists, some of us are rehab physician, but in our team, we also have a psychiatrist who is a pain specialist, a pediatrician, and also a geriatrician. So, you know, 8 of us is quite a good mix of pain specialists. So these are our geographical location: in Darlinghurst, Randwick, Kogarah, and Hurstville. And what do we normally do in a multidisciplinary pain clinic? So we spend a lot of time on the first consultation. As I said, comprehensive assessment, looking at the biomedical costs, looking at their function, their psychological and social status. And also we look at their medication that they are taking. A lot of times when patients present to us, they would have seen a few other specialists, a surgeon or another pain specialist, and some of them have already on 2 or 3 different kind of pain medication, whether they're simple analgesic like paracetamol or non-steroidal. Some of them is on opioids or on anti-neuropathic agents. So we try to optimize the analgesia. And I talk about some interventional procedures that we do in our service. A lot of the patient is referred, because we work in 3 or 4 different private hospitals. We work with a lot of different neurosurgeons. So we get a lot of referrals, especially for lumbar cervical injection, because we assess the patient, and the procedures that we do, which is a bit different from radiologists, is we do diagnostic block, and if it's positive, we can offer something that can provide patient a bit longer duration of pain relief, like radiofrequency ablation. And we don't use a CT scan to perform our procedure. So we're using live fluoroscopy with less radiation. And we usually assess the patient first to find out where the symptoms are, so that it correlates with the imaging scans. So we don't just treat the scan, we treat the patient's symptoms. And because we can do it under a bit of sedation, and we know, let's say in older patient that I see, especially in an area that I work in, especially in Darlinghurst or in the south, where I get a referral from retirement, retirees living in Vaucluse area or in the Shire, Sutherland Shire, for older patient who had multi-level problem in the spine. And, you know, some of them are 85 years old, 90 years old, and with a lot of medical comorbidities, they are not a candidate for multi-level fusion or surgical decompression. So we can do actually minimal invasive procedure, radiofrequency ablation at a multiple level at one sitting. And we provide very minimal sedation so that, you know, to take away the discomfort from all the needling work. And then we assess the patient 2 to 6 weeks after the procedure, so that we know that if it works for them, we want to look at reducing their pain medication and also send them to physiotherapy or upgrade their physical function and exercise regime. Now I want to zone into some of the condition I see a lot. Of all the pain condition I see, I think 50% of the pain that I see most in my clinic is back pain. And with back pain, you know, I can classify back pain with just back pain with no leg pain, no radicular pain, and also back pain that is coming from the lumbar spine, or sometimes in a younger patient. Most of the back pain are muscular in origin, but I want to focus on some of the treatment that we carry out in our service that it has been very beneficial for some of our older patients. So if you're looking for just axial back pain coming from a lumbar spine, there's only 3 areas that the pain can come from. We're not talking about radicular pain, leg pain due to the nerve root compression. We're talking about axial back pain. Most of them is coming from the facet joint, followed by degenerative disc or disc protrusion, or very, very rarely, if a patient had osteoporotic fracture or traumatic fracture, then the pain can come from vertebral body. But you can see this graph here for axial back pain coming from degenerative causes, especially for facet joint. It increases when we get past 50, 60 years old. So in the younger population, facet joint arthritis is not a problem. So how do we diagnose facet joint? First problem, I think I see it a lot in my clinic. I would say out of the 30 patients I see a day, at least 10 of them will have presented to me, if they're older generation in the 65 and above, they would have some form of facet joint problem, followed by some degenerative disc. So this is how we grade the facet joint arthropathy. So you can see here the 4 grades. Grade 0 is no narrowing in the facet joint. This is axial cut on the CT scan. Grade 1 is a bit of joint narrowing. This is the right side, left side. And grade 2 is a bit of narrowing with a bit of osteophyte formation. But when it's a severe, apart from the joint narrowing, there's also sclerosis and a lot more bone spur, which is osteophyte. So you can see here, there is on the left side, there's severe facet joint arthropathy. And again, we can also diagnose that on a what we call a sagittal cut. You can see here facet joint, especially on L4-5 and L5-S1 on the right-hand side. This is what we call facet joint arthropathy. And usually we can also carry out some examination. We ask the patient to turn, rotate to the left or right. Let's rotate to the left and then ask patient to tilt backwards, look up. So we're putting a bit of what we call an axial load on the facet joint. And if that exercise create pain, there's a name for this test called KEMP test, KMP. KEMP test is positive, then we are more suspicious of a facet joint problem. And then we confirm it with either a CT scan or a bone scan with SPECT CT. So this SPECT CT, you can see here, the CT scan shows L5-S1 is joint narrowing and is increased uptake with a SPECT CT. Again, you can see on an axial cut, a sagittal cut, and coronal cut, where facet joint problem is actually a postural segment problem. But if you see in the SPECT CT, there's increased uptake in the anterior segment, whether it's in the vertebral body or the disc, then this is unlikely to be facet joint problems. So the treatment will be different. So how do we treat facet joint problem? If you refer this out of patient with back pain with facet joint problem to a neurosurgeon, most of the time neurosurgeon will say, go to the radiologist or go to the pain specialist who does it's just a simple injection. This sort of back pain due to facet joint problem, the patient is not a candidate for surgery unless the patient has what we call foraminal narrowing, compressing on a nerve root. So treating the facet joint problem is very easy because we know the facet joint is innervated by the facet medial branch nerve, thanks to a pioneer in a specialist who comes from Newcastle up north. Dr. Nick Bogduk actually did a lot of cadaver dissection, and then he found out that facet joint is innervated by 2 medial branch nerves. So let's say in this diagram, if you're going to target a right L4-5 facet joint, you need to block the L4 medial branch and an L3 medial branch. So it's very simple. So we'll do a diagnostic block. If the block is positive and the patient had good relief for a few days up to 2-3 weeks, then when the pain comes back, we can actually book the patient for a radiofrequency ablation. We also tell the patient with radiofrequency ablation targeting a facet joint pain, you will have duration of pain relief for at least 6 to 12 months, on average of 9 months. So the procedure is carried out usually in day surgery with a bit of sedation. We place a patient on the tummy, give them a bit of sedation, and then we connect the patient with a grounding pad and we use the live fluoroscopy to guide our what we call cannula in to place it on top of the meter branch, and then we stimulate and make sure that we stimulate the right nerve, and we get a multifidus muscle stimulation. Then we know we're in the right position, and then we start the radiofrequency ablation. So there has been a lot of advancement in technique to actually improve our outcome and also improve the duration of the pain relief. Now with proper cannula and also how we place the cannula and a needle, we can actually achieve a bigger lesion on the nerve. So it will take longer time for the nerve to recover to establish, the pain signal again. So if we are able to place the cannula on top of the medial branch nerve, parallel to the nerve, we will be able to ablate the nerve and provide pain relief for at least 6 to 12 months. So this is just a simple radiograph that the live radiography that we do to find out where we can place the cannula. So we usually do an oblique view to see the Scotty dot view. So medial branch nerve runs on this white dotted line, and then we place the needle on the white dotted lines, do an AP, confirm with the lateral to make sure that the cannula is on top of the medial branch nerve. So I just want to give you an example of how some of the patient that you might see in your clinic that is in the age group between 60 to 90 years old has had pain for a long time. And this sort of patient, if they don't have severe leg pain, and they could be a candidate for a CT scan or bone scan or MRI. And once we diagnose the condition, then the treatment will be very straightforward and provide patient a good outcome. So first case, a 77-year-old lady, which I've been seeing for the last 3 years. Prior to when I saw her, she's been complaining of lower back pain for 4 or 5 years, not much of the leg pain. She's been taking Plexia, immediate release, 50 milligram PRN and Voltaren PRN. But imaging shows she has multi-level degenerative changes. You can see here, this is the MRI of the lumbar spine for this patient, 77-year-old. So you can see there is some disc bulge and a bit of facet joint arthropathy causing a bit of stenosis. But because this patient doesn't have radicular leg pain and no radiculopathy, so this patient already seen a surgeon, and surgeon said, you don't need any decompression surgery. What we can do is refer you to James, some of the pain interventional specialists, to do some radiofrequency treatment to reduce their back pain. So you can see here facet joint arthropathy, and if we look at the axial cut L3-4 and L4-5, again the facet joint, the joint space is narrowed. There's osteophytes, and this patient we also did, because there's 2 or 3 levels of arthritis, we did a bone scan and SPECT CT to make sure that the pain is actually coming from the L3-4 and L4-5. So you can see here L4-5 lights up with a lot of increased uptake. So with this patient, 2-level problem, both sides. If you refer this to a radiologist, they will do one side, 1 level each time with cortisone injection. So by the time, we're going to treat 3 levels on the right, 3 levels on the left, the patient would have been to the radiologist on 6 occasions. So for this patient, we can actually, do 3 levels on the right, 3 levels on the left, and the same setting within 20 minutes with minimal sedation. So we place the patient in prone position and insert 3 cannulas targeting L2, L3, L4, which supplies the 2-level of facet joint on the right side. And then while we're doing the radiofrequency on the right side, we can place the cannula on the left side on the corresponding 3 levels. And we confirm with the AP, make sure that it's in a good position. And also make sure when we do a lateral, they are not too anterior where the nerve root is. So once we get this picture and we do a motor stimulation and we're satisfied with where the position of the cannula, then we start the radiofrequency ablation. And this procedure only takes about 15 to 20 minutes. with very minimal sedation, no manipulation of airway, and the patient wakes up in recovery, and within an hour, patient can get home. So the patient will only be in the hospital for around 3 hours, half a day for this procedure, and then they will get about 6 to 12 months of pain relief. So I like doing this procedure because I see a lot of good outcome for a lot of my patients. Whereas a lot of these patients, they don't have, they're not complex pain patient with lots of opioids or psychological issues. So I like this kind of patient. And so facet joint pain is a problem for lumbar spine. Cervical facet joint is also a problem. And cervical facet joint pain accounts for about 40 to 60% of neck pain that I see, especially if patient have in an older population in the 70s, 80 with neck pain. We're not talking about radicular leg arm pain. We're talking about just axial neck pain, or younger patient in the 40s, 50 or 60 that has a whiplash injury, like if some gentleman has played a lot of rugby, football when they're young, or some patient in the 50 or 60 who had a whiplash injury from motor vehicle accident 5 or 10 years ago, then this whiplash injury 5 years later can create some degenerative changes, especially facet joint arthropathy in the neck. And one good thing about diagnosis of cervical neck pain, they are very, very uniform, that by asking them where the site of their pain, you kind of know which level is the arthritis. So I want to just focus on how to diagnose with just the symptoms. If we ask the patient, where is your neck pain? We divide in 3 regions: upper neck pain, middle neck pain, or lower cervical neck pain. So if the patient say is upper neck pain, is usually C1, 2, and C2, 3. If it's a middle neck pain, around here, what I push, is usually C3, 4, C4, 5. But if the patient say, I have neck pain on the base of my neck, sometimes going down to my scapular region, is usually C5, 6, and C6, C7. So kind of like if you know where the pain is, and then on the CT scan or bone scan, you look out for the changes which correlates with the symptoms. Because some patient might be 80 years old and all their cervical spine are showing arthritis, but then you don't want to treat the scan, you want to treat the patient's symptoms. So how do you differentiate C1, 2 from C2, 3 with upper cervical neck pain? So it's very easy. C1, 2 usually older population, 75, 80, 85, and they can't turn their head to the left and right. So you ask them to turn to the left, they can, but then when they turn to the right, it's painful, and that they have right side upper cervical neck pain. Most likely you want to look out for C1, C2 joint, because it's an atlantal axial joint that lets you do lateral rotation. So this is just an example of some CT scan that can help you diagnose facet joint. So the corona view, you can see the facet joint at C2, 3 is showing a bit of narrowing, a bit of bone spur. And then this is what we call the sagittal view. So 2, 3 facet joint, C3, 4, C4, 5 shows a joint narrowing. But the 5, 6, and 6, 7 is a normal facet joint. And you can, let's say, if you do a CT scan, there's a lot of levels of arthritis, and you want to make sure that you only want to treat 1 or 2 apart because a patient had a middle neck pain. Then you do a bone scan, and if it lights up like a bulb, this is on the left side, C3, 4, and it correlates with the left side neck pain, middle, then that is the money where you want to target. So I'll give you an example. Again, a lot of my patients who suffer from facet joint problem with no radicular symptoms are usually in the late 60s, 70, and 80 years old. This lady is 74 years old. I've been seeing for the last 2 years, complaining of right-sided neck pain, middle to lower cervical region. It's quite a big area from upper middle to lower. So now we know middle and lower, so we're going to look for C3, 4, C4, 5, C5, C6. There's no radicular arm pain. Patients take Lyrica, 75 milligram twice a day, Panadine 4, PRN, sometimes 2, sometimes 4 a day for this pain. So we look at an MRI, sagittal view, you can't see any nerve compression at all. So, but some of the scan that we can do this, oblique sagittal view. This is the right side, the left side, and then you can see that now the facet joint problem is become a bit more obvious. And now we can look at the right side. This is the MRI axial cut. There is actually a facet joint narrowing, and also what we call osteophytes formation. Then we correlate with the CT scan, an axial cut. You can see the C3 facet joint narrowing, C4-5. This is actually grade 3, where there's joint narrowing, there's osteophyte, and also sclerosis, and C5-6, there's also joint narrowing. So there's out of 3 levels, 2 levels are grade 2, and 1 C4-5 is grade 3. So we can actually book this patient to do 3 levels, on the same setting. So we know that cervical facet joint is supplied by 2 nerves. Again, through a cadaver dissection, we know that, let's say you want to have problems with a C3-4 facet joint, you got to target the C3 and a C4 medial branch. Whereas a C2 facet joint, you need to target what we call third occipital nerve. And we know that the medial branch nerve runs in a similar fashion in more than 90% of the patients. So if we place our cannula at that area and do some stimulation, and we know that we will be able to ablate the medial branch nerve and provide significant pain reduction. So this patient has, had 3-level problem: C3, C4, 5, C5, C6 on the right-hand side. And you can see this patient is on prone. This is on the right-hand side. This is C3-4 facet joint. You can see there's a osteophyte. C4-5 is not just osteophyte, and the joint space is narrow, and then C5-6. So we can actually target 3 levels at once by placing 4 cannulas. So because sometimes C6 is very hard to see, so we do a lateral. So we target C3, C4, C5, C6, then we can cover 3 levels of the facet joint problem. And then we can do what we call a contralateral oblique to allow us to look at the cannula a bit better, so that we know that we're in a good position. So again, those procedures only take about 20 minutes, and patient will have good pain reduction and outcome for usually we say about 60 to 80% of pain reduction for 6 to 12 months. So now we want to go back to the commonest back pain and pain condition I see. I see a lot of lower back pain because I work with at least 10 to 15 neurosurgeons in the east, in the south, so sometimes in the west region. So I see a lot of patients who's referred after having 2 or 3 lumbar spinal surgery. So this is again a 78-year-old patient who has had 3 lumbar spinal surgery in the last 5 years, including now having an L4 to S1 fusion 2 years ago, still presenting with lower back pain, bilateral leg pain. So then we want to know why the patient is having pain. Is the pain still coming from the L4 to S1 region, or is it coming from the adjacent level, which is, that if we fuse the spine at a particular level, let's say in this patient L4 to S1, and then after 2 to 4 years, because that region is fused, so the level above and the level below will take all the pressure. So you can see in this patient, the level above L3-4 and L2-3, they're showing some degeneration. So this patient had adjacent level disease and has been taking opioid medication, Targin and Endon, up to 2 a day, for the last 2 to 3 years, and started to develop some opioid tolerance. So what we want to do is we send the patient for a CT scan, and we found out that the level above has some problems. So we did a very simple procedure, targeted the L1 and L2 medial branch to help with the facet joint problem with both sides, but it's provided patient only about 4 months of pain relief. And it's short of the 6 to 12 months that we want. So the patient wanted something that is a bit more permanent. So what are the options that we can offer the patient is again, we actually send the patient back to the neurosurgeon to just make sure that this patient doesn't want to go through another surgery. So this patient has already had 3 surgery, and the surgeon says, maybe, go with a spinal cord stimulation trial. If it works, then, we can manage your pain. We don't need another 2 levels of fusion. So we trial this patient with spinal cord stimulator. We place 2 electrodes in the epidural space across T7 to T9. Trial with 7 days with an external battery. And this patient has what we call reported about 80% of pain reduction after 7 days. And apart from pain reduction, there was a lot of improvement of function and sleep. And during this, during the 7 days of a trial, and the patient stopped Targin and Endon. So this was a very good outcome for the patient. So we removed the electrodes. 2 days later, the pain came back. So she's back on taking Endon medication, but she stopped her Targin. Then what we did is 4 weeks later, we placed the same type of electrodes, one on the right of midline, one on the left of midline, place it over T8 to T10 at the posterior epidural space, and connected to what we call a pulse generator, which is a battery, to have ongoing stimulation to provide what we call stimulate across the CSF, targeting the dorsal horn of the spinal cord to block the pain signal. And this patient has been very happy for the last 18 months using her spinal cord stimulator, and she stopped her Targin and Endon medication. So now we want to go back to the first case, the quiz number 1 on my second slide. We've gone through that this patient has had 15 years of lower back pain, has had 2, 4, 6, 8, 10 levels of spinal fusion from T10 up to, S1, S2. Patient is on, you look at the lateral X-ray, all the spine is fused. Patient's on Norspan 10 microgram per hour, Lyrica 150 milligram BD. And, what else? What are the treatment options? So patient is not keen for another surgery. I can't find anywhere I can give the patient an injection of radiofrequency to target. And patient is already on kind of like anti-neuropathic medication and opioid medication. So the option I can offer the patient is a trial of spinal cord stimulator. So before we put a spinal cord stimulator, I want to make sure that there is no scar tissue or stenosis in the epidural space for me to place electrode. So I send a patient for a lateral, thoracic and lumbar spine MRI. So looking at the thoracic MRI and the sagittal segment, I want to make sure this white line, the posterior epidural space, there's at least 2 centimeters of space for me to, insert the electrode. So this patient, even though has 10 levels of spinal fusion, but his epidural space, is capacious for me to place electrode. So what we did is we booked this patient in for a trial with the insertion of 2 electrodes. We did it really very, carefully, because we have to go through a lot of scar tissue, but definitely there's no scar tissue in the epidural space. You can see the foramen is quite capacious. So we managed to put 2 electrodes from T7 to T910. So you can see the top screw is at T10. Some of the rods go up to T9. So we have to go past all this fusion surgery. And this patient also had what we call open heart surgery in the past. So we trialed this patient for 7 to 10 days. And this is a brief pain inventory that we see the patient, 7 days after the trial. And this patient has rated their pain reduction now from 8 out of 10 down to 1 out of 10. And also a 90% of pain reduction. And we're still using Lyrica and Norspan. But a lot of the function has improved. And because this is, as a given patient 80-90% of pain reduction, 4 weeks later, 5 weeks later, we implanted the stimulator. And then 2 weeks after the implant, we assessed the patient again in March this year. Again, this patient has, say, a bit of post-procedural pain, but generally pain score is good. Patient has stopped the Norspan patch just on Lyrica, And the only problem the patient has is they're happy with all the general activities and mood. The only problem now is the walking activity. So we send the patient now to physiotherapy and start doing a lot of walking, a lot of mobility exercises. And now, 5 weeks ago, I saw the patient. That was 3 to 4 months after the implant surgery. This patient is actually walking much better and walking quicker than his wife. So now the wife is actually had to catch up with him. So it makes me really happy, apart from just not just getting his pain down, even when he has pain after 5 spinal surgery and 10 levels of fusion, we were able to reduce his pain down to 1 to 2 out of 10. We're able to stop his Northpan medication. And now we've referred the patient to physiotherapy and improve his mobility. Now he's actually walking faster than his wife. So you can see that, we're not just treating the patient's pain, but we also want to improve patient function and quality of life. So this is the X-ray that we took for the permanent implant, where the electrodes is across T7 to T10 and in the posterior epidural space. So we know that, spinal cord stimulation is not for everyone. We only, in our clinic, there'll probably be only 5% of the patient that we will actually recommend this type of therapy. Usually it's a patient who has had 1 or 2 spinal surgery and still have a lot of pain and don't have a lot of psychosocial issue. So we know that spinal cord stimulation is unlikely to work, and we will not recommend the patient if patient, is a patient who presents with a lot of pain, widespread body pain, whether you shade it, everywhere pain, or the patient put a lot of dots in everywhere on the body. So we know that if patient has fibromyalgia with central sensitization, most likely the spinal cord stimulation is not going to work. If the patient has extensive muscular problem, myofascial pain from head to toe, is unlikely to work. If a patient who is in active work cover claim with a lot of secondary gain, doesn't want to go back to work, it's unlikely to work for them. Or if patient suffers from severe major depression or severe psychology disorder with general anxiety, long-standing bipolar disorder or PTSD, and we know that it's unlikely to work too. And also another group of patients who use high dose of opioids with oral morphine equivalent of over 100 milligrams a day. And we know that this type of patient might have opioid-induced hyperalgesia and a lot of pain intervention or spinal cord stimulator would not work in this type of patient. So then we have to look at what we call the 5 pillars of multidisciplinary management, with a lot of patient education, psychology therapies, and physical therapies, with a bit of minimally invasive intervention. So again, now we're talking about opioid medication. This is again quiz number 2. We know that this patient, from his history, 2014 was taking about half the opioids he was taking 4 years later. So in 2018, a few months before I saw him, his GP has referred him to see me because the previous pain specialist prescribing him a lot of opioid medication, and his oral morphine equivalent is about 480 milligrams a day. So it is a lot of opioid medication. So as I said, this patient has opioid tolerance, opioid-induced hyperalgesia. So a lot of intervention is not going to work. So how do we treat this patient? So when this patient saw me 3-4 years ago, a lot of opioid rotation has been trialed in this patient. He's been on rotated MS-Contin, hydromorphine with Junista and Dilaudid, and Fisepton, which is methadone. But the patient could not tolerate or didn't like the medication. So every time he swapped to one opioid, a few weeks or months later, he wanted to come back to the oxycodone. And he'd been trialed on some anti-neuropathic medication, Lyrica, amitriptyline, had 2 ketamine infusion, and he's been referred to undergo a pain management program in Royal North Shore Hospital. And also he's had a spinal cord stimulation trial. As I said, spinal cord stimulation would not work in this patient because this patient had a lot of central sensitization from opioid-induced hyperalgesia. So how do we treat this patient? Some of you might have this type of patient. We find it, this will need what we call a multidisciplinary management. We might have to include the psychologists, the physiotherapists, psychiatrists, drug and alcohol specialists. So we discussed about the treatment. There's increasing dose of oxycodone in the last 4 years, but there's no improvement on symptoms. Patients now getting a lot of brain fogginess, a bit of drowsiness. So there's only 2 choices: either opioid substitution to Suboxone, and now we have this availability of if the patient trial oral Suboxone for a few weeks and is happy, then we can actually refer to see a psychiatrist or drug and alcohol doctor to have what we call buprenorphine injection weekly and then monthly. Or, we can actually run ketamine infusion, reduce his opioid consumption, and then trial him on an intrathecal morphine. So this patient didn't want to try another opioid, oral opioid like Suboxone. So we said, maybe we can trial you on an intrathecal morphine. So we did a trial, give him an intrathecal morphine of just 0.4 milligrams, so less than half a milligram in the intrathecal space. And, we actually did it via catheter over 3 days, 0.4, 0.4, 0.4. And we assessed, and the patient said, well, great, I had good pain relief. And then we actually kept the patient in the hospital, run some ketamine infusion. And over the 5 days, we were able to reduce his oxycodone from 480 milligram of oral morphine equivalent down to around 180 milligram. So with 180 milligram of oral morphine, we're able to play with a smaller opioid doses, compared to three times the opioid doses we were managing. So with that amount of opioid requirement daily, so we put an intrathecal pump 4 weeks later, running at 0.3 milligram a day. But then, we had to escalate it to 3.35, and now is running at 0.4 milligram a day, which is less than half a milligram a day compared to when he was taking 480 milligram a day of morphine equivalent. And now he doesn't take oral opioid at all, which is a good outcome for the patient. So again, intrathecal pump is not for everyone. I only do about 5 pump a year maximum, and probably less than 1% of the patient population I see is indicated for this intrathecal pump. We do intrathecal pump for cancer pain, especially if you know that they have life expectancy beyond 6 to 12 months, and it works really well for cancer pain, and also works well for chronic pain, that patient that doesn't want to have ongoing oral opioid or has some side effects from oral opioids. So a pump is inserted, and an intrathecal catheter is inserted, usually for back pain and leg pain. We'll put the catheter up to around T7, T8, connected to a pump. A pump is usually in the abdomen, abdominal wall, usually below the rib and above the what we call iliac crest. So again, on a summary on opioid management, if you're a patient who abuse opioid or overuse opioid, with this, there's a term what we call opioid misuse disorder. So they can develop not just opioid tolerance, they can also develop dependency and further on addiction. And how do you manage this patient? So there's a few ways that pain clinic can help your patient. Either you can refer to a pain clinic or drug and alcohol specialist. This is the 5 treatment option that we can offer the patient. Opioid rotation to a partial agonist. So we can rotate this, what we call full agonists like oxycodone, morphine, hydromorphine, fentanyl patch, to a partial agonist. Partial agonist is a better opioid to handle because they don't cause what we call opioid-induced respiratory depression or overdose and death. These partial agonists are like tapentadol, Plexia, buprenorphine like Norspan patches, or Temgesic, or Suboxone, or Tramadol. So I would say Tramadol, Plexia, buprenorphine is actually a partial agonist. It's probably safer than the full agonist opioid. Or we can actually ask the patient to see a psychiatry or drug and alcohol for drug detox in a hospital. But this is a very difficult situation for the patient. Usually with chronic opioid misuse, patient could not tolerate 1 or 2 days of what we call withdrawal symptoms. They will go crazy and had to have a lot of clonidine and benzodiazepine to help in a drug and alcohol rehab. But what we can also advise the patient is opioid reduction. Every 4 weeks, we can reduce 10 to 20% of the opioids, especially when the opioid dose is not too high, usually around the 50 milligram to the 200 milligram a day of oral morphine. We can reduce the opioid probably 10, 20% every 4 weeks. And the other thing is also we can bring the patient in the hospital, run ketamine infusion, and then we can reduce 20% each day. It's a quicker win of the opioids. And then at the end of 5 to 7 days, the opioid consumption is down to around the 10, 20% of when they come in. And the other thing is opioid substitution, as I said, with a Suboxone, then with a Buvidal injection, which one of our psychiatrists in our service, pain service is offering. And last but not least, like the patient I presented before, intrathecal morphine pump. So I have another 10 minutes of presentation. I know I talk a lot about intervention, especially for back pain, neck pain, cancer pain, and intractable pain and also with patients who have opioid misuse disorder. Now I want to look at some very common condition that I see that needs urgent treatment, where we can offer simple intervention and multidisciplinary management to improve the patient function. One of the conditions I see a lot in our clinic, because I work with also a lot of orthopedics, hand surgeon, orthopedic foot surgeon. So we see a lot of what we call a complex regional pain syndrome, so CRPS. So when a patient presents to you with acute or subacute or chronic pain, 3 months, sometimes we present after 2 years. When I see a patient present with hand pain or foot pain, swollen, red, tender to touch, warm or sometimes cold, and when you have pain for 6 months, 12 months, then all the CRPS patient can come with a lot of other complex issues. A lot of them will be depressed, anxious, and has a lot of physical decondition. Sometimes when a patient presents after 12 months, their hands will be in the what we call fixed flexion position. This is what we call physical decondition, fear avoidance. And if you put your hand close to the hand, they will actually draw away because they're so scared that you touch them and you cause pain. So this is what we call fear or pain, fear avoidance. When the patient is so scared to move their arm because it causes pain, and after 3 months or 6 months, they haven't moved it, the hand will be in a fixed position. And if the patient's hand is arm is in a fixed position, they don't move the elbow, they don't move their shoulder, when we tell the patient, if you don't use it, you're going to lose it. So now, apart from treating the CRPS pain, we have to treat the elbow joint problem and also a lot of shoulder joint problem and all the muscular spasm in the arm. So it becomes a big problem. So if you have a patient that presents to you within the first 6 to 12 months of this issue, please refer to the pain service, either in a public or a private hospital, that we can involve this patient in simple intervention like stellate ganglion block, and then get the patient to do a lot of physical exercises with the physio, especially active exercises. We also have brain exercises because we know that sometimes after 6 months, there are brain changes that we know from research function, MRI, there are actually changes in the brain. So now it's not just a peripheral problem, it's also a central problem. So we involve the psychologists and physiotherapists in what we call multimodal, interdisciplinary management. Again, CRPS can happen in the foot too, especially in young ladies who is very active in the curriculum and also extracurricular activities. Sometimes they play netball or dancing or gymnastics or basketball and have a very mild ankle sprain. and the leg becomes red and swollen, and it's tender to touch, warm, and sometimes it's very, very sensitive. So again, we want to diagnose this early so that they can have better outcome. If they have a simple nerve block, to reduce a sympathetic nerve dysfunction. This is what we call targeting the sympathetic ganglion, usually at L2, L3, and L4. And we can reduce the pain and then refer this patient to physiotherapies, to do a lot of brain exercises, visual exercises, and a lot of lower limb exercises. And also, I would like to, we do a lot of radiofrequency ablation technique. And these days, we get a lot of referral from knee surgeon, because some patients are too young to have knee replacement, and some patients are too old. So usually the patient that's, a good age for knee replacement is between 50 and 75. So if the patient is below 50 and have, moderate osteoarthritis, patients are usually not a candidate for knee replacement. If the patient is over 80 years old, had a lot of medical comorbidities, and a lot of the knee surgeon would refer us to do what we call pain intervention treatment to get the pain better and then improve their physical function with quadriceps strengthening exercises to improve their mobility. So again, with knee osteoarthritis, we can also reduce the pain by targeting what we call genicular nerve and do a radiofrequency and improve their pain. But if for the younger patient, let's say below 50, has a bit of mild and moderate arthritis, we sometimes also recommend what we call PRP injection, platelet-rich plasma injection. So PRP injection has been known to be used by the sports physician for a lot of elite athletes over the last 10 to 20 years. But over the last 5 years, PRP has been used a lot for chronic pain patient. There's a few regions that PRP works really well. For me, it's the knee joint, mild to moderate arthritis, shoulder joint, a bit of what we call tendinitis, tendinopathy on the rotator cuff, supraspinatus, hip joint osteoarthritis, and also elbow pain with tendinitis, either tennis elbow or golf elbow. PRP or platelet-rich plasma injection works really well. Now, this is what we do. We usually target, for this patient, you can see the lateral compartment, there's kind of like moderate to severe joint arthritis. And on the middle compartment, there's only a mild osteoarthritis. So we targeted the genicular nerves on 3 sides. We're able to reduce the pain for at least 6 to 12 months. So we talk about PRP injection in the knee, in the shoulder, and the hip. But for discogenic pain, when the pain is not coming from the facet joint and nerve root, and when a younger patient below 50 years old and has ongoing lower back pain, and we know there's degeneration disc, there is some evidence that putting some PRP injections into the disc, actually, over 2 or 3 occasions, we can actually help reducing some inflammation and look at reducing the pain, and hopefully in 6 months' time there's some regeneration on the what we call cells in the disc. So a few years ago I published what we call a review article on PRP injection for chronic lower back pain, and in this article there's about 11 studies. And 2 of the studies are a really high-power study, one from Canada by Levi and one from New York. And this is the one that also another study from Korea, where they had quite a bit of treatment. Apart from using PRP, they also did a pulse radiofrequency treatment on the disc by doing a pulse radiofrequency for 15 to 20 minutes. They can also see some improvement in the pain, the Ovestre disability score, and also the sitting time for the function. This is a 12-month follow-up study, which shows significant improvement in a lot of outcomes. So what we've been doing with working with a neurosurgeon for younger patient who is not a candidate for fusion surgery or total disc replacement, and who didn't respond with epidural injection or physical therapy, sometimes we recommend some what we call intradiscal minimally invasive treatment, injecting some PRP, about 2 mils of PRP in the disc, followed by a pulse radiofrequency treatment. So you can see this patient. She's only about around the 48-year-old mark, and the disc is collapsed, but it's not severely collapsed. And then what we did is put a needle into the disc, did a contrast, and make sure that the needle is right in the middle of the disc. We'll put 2 mils of PRP and did some pulse radiofrequency treatment over about 15 minutes. We assess, we do repeat this procedure about 4 to 6 weeks later, and then we assess the patient. And I get about 60 to 70% of patients actually reported significant pain reduction. And then we refer to the physiotherapy to improve their physical function, working on a core muscle and also a back muscle to strengthen the muscles to stabilize the spine so that the disc doesn't collapse any further. So I think I've done 60 minutes of a presentation. The last 5 minutes, we want to talk about, how with pain management, we're not just looking at improving the pain symptoms. We also want to improve the function. We refer to physiotherapies, occupational therapies, to see how else we can, improve, the mobility, the exercise regime, stabilize the spine, in what we call reconditioning of the muscle activity. And also we look at the mental health and also the social situation to see how we can improve the quality of life. So again, so at the end of these activities, this simple, straightforward patient, you'll be able to manage this patient in your clinical practice or the specific diagnostic test. If it's XL, it's only back pain and neck pain with no radicular arm pain, a CT scan or a bone scan would be adequate. But if a patient has radicular arm pain, let's say a patient has arm pain all the way down to the thumb, then we know that it correlates with C6. A CT scan and bone scan is probably not adequate. You would need to do an MRI. Same goes to lumbar spine. If the patient has back pain and radicular leg pain down to the ankle, if you have pain going down to the ankle, then we think it's the L5 nerve root. CT scan and bone scan is probably not adequate enough to diagnose nerve compression. You will need to have an MRI. So today, my talk, we did not talk about radicular leg pain or arm pain, but we can probably cover it in our discussion or next session. And hopefully, you know how to differentiate axial back pain, CT scan, bone scan. If you've got radicular arm pain and leg pain, MRI. And then refer, if they have nerve root compression, refer to a neurosurgeon for decompression, or the nerve compression is not severe, you can refer to a radiologist or pain specialist for a simple epidural injection to reduce the pain. But not all chronic pain patient is so straightforward that you can manage with just simple history, investigation, examination. A lot of our chronic pain patients is very complex with a lot of psychology problem, physical problem, because they haven't exercised for a long time. They don't walk for a long time because they have pain. All the muscles get weaker and be deconditioned. And some of them have a lot of social problems. So in this type of patient, that's why we need a multidisciplinary management, what we call 5 pillars of pain management, not just medication, but a lot of patient education in a team with nurses, psychiatrists, psychologists, physiotherapy. And also we do a lot in our pain, senior spine and pain services. We offer minimally invasive procedures, sometimes a little bit like spinal injection, nerve block, radiofrequency treatment. But for some of the patients that want a bit longer duration of pain relief, the spinal cord stimulation and also intrathecal morphine pump that we can offer. So again, thank you for your attention. This is my personal email, which you can email me if you have any complex patient or even straightforward patient, older patient from 65 to 90 years old who had axial neck pain and back pain, who the neurosurgeon will probably say, go to see James. He can help you very easily. So you can look into our website, Senior Spine and Pain, or this is our clinic phone number. Thank you so much.
Thank you so much, James. That was really interesting. And I think it's really helpful to know about what the options are, I guess, for treating our patients who, that's right, have pain that is difficult to control, I guess. There's a few questions, but I just wanted to start with one from myself. I sometimes find it hard to get patients to sort of buy into things like physio and psychology and patient education. Do you have any tips in helping make patients a bit more keen to do those sort of things as well?
Yeah, so I think a lot of that, it will start with the patient education. So we sometimes have a lot of patients, when they present to us, they have seen a neurosurgeon, they've seen a lot of physio, and sometimes with acute pain or subacute pain, less than 6 months, sometimes a lot of the patient will improve with what we call passive kind of physiotherapy, a bit of massage therapy, a bit of manipulation. Sometimes some physiotherapy provide what we call simple TENS machine or acupuncture. Those are therapy can help with acute or subacute pain. But for chronic pain patient, this sort of therapy doesn't work. So some of these patients don't buy into physiotherapy because they have gone through a lot of physiotherapy. And they come with a mentality that, oh, I got back pain, must be my spine. You got to fix my spine. So it's a lot of time has to be spent with the patient. First thing is patient education. We actually show them the scan. We show them the surgeon's report. Say, I usually open up the MRI scan or the CT scan and show them, hey, look here, you can see this is a disc, this is a nerve, this is a vertebral body. They are all very good. Or some of the patient who has gone through surgery, hey, look at the fusion. The fusion is really good, solid. The fusion has taken place. There's no longer any nerve compression. There's no longer joints are rubbing. So now we are not treating your spine. Even let's say we correct your spine or send you back to the neurosurgeon to do another surgery, your spine will look good, but there's no guarantee that pain will get better. So there's a lot of time need to spend with the patient. Chronic pain is far more complex than a spinal issue. Your spinal issue has been treated, repaired. Now you still have pain. We're going to look at chronic pain. Chronic pain, you need the pain to the nerve to send a pain signal through the spinal cord to the brain. And if you have this signal sent to the spinal cord to the brain 24/7, you will have this complex issue. You can't sleep. You're very anxious. You're stressed all the time. And then you don't sleep. You wake up feeling tired. All your muscles, you don't go out. You don't leave the house because you're scared when you go out. You have pain. You rush home to want to be at home. So they understand these are all very, very complex patients, and all their situations are the same. They're all physically conditioned. They're all socially withdrawn. So we explain to them all this complexity. They understand. So we think by managing your pain is not so simple. We set expectation. If we do another injection or surgery on your back, there's no guarantee that we're going to get your pain down. But if we are able to put you on some simple medication, change a bit some of your medication, do some simple procedure, and then we can reduce your pain by 30–50%, get you to see the physio and psychologist, and all work together to improve your pain. So, but you need time. So, and then also you need a team of physiotherapists and psychologists that also, knows how to treat a chronic pain patient. Set the expectation, tell them the same story. If you don't move your arm and your legs, in 6 months' time, you're not going to be able to move them.
Yeah, thanks. There's a few questions here from the audience. So I'll just start at the top, I think. So the first one is, can you explain again about which of the medications are the partial opiate agonists for those patients who are taking opiates?
So opioids, partial agonists, there's only 3: tramadol, tapentadol, which is Palexia slow release or immediate release, and buprenorphine, which buprenorphine can come with Norseman patch, 5, 10, 15, 20, 25, 30, up to 40 milligram or microgram per hour. Buprenorphine also can come in a form of 10G-sig, 200 microgram, can come in the form of Subutex, which is not very common now. Most of the Subutex are now Suboxone, which is buprenorphine and naloxone. So we got 2 milligram, 8 milligram. And now, over the last 12 months, there is 2 types of buprenorphine injection for, opioid replacement therapy, which is Buvidal. So these 3 types of opioids are what we call partial agonists. For pain specialists now, over the last 5 years, initiated pain specialists, we are steering away from full agonists, because we know that full agonists, if a patient taking oxycodone, morphine, fentanyl patch, hydromorphine, these are full agonists. If you're escalating the dose, when they take too much, there's a risk of overdose, opioid-induced respiratory depression, overdose, and death. And in America and also in Australia, we have seen a lot of death due to opioid, whether it's a fentanyl patch or oxycodone. So we are moving away. We want to swap the patient to partial agonists. If you think the patient, like 80 years old, that, has seen a lot of specialists, done a lot of surgery, and has a lot of comorbidities that, patient doesn't need another, it's not a candidate for hip surgery or spine surgery. Sometimes you can put them on a 5 microgram per hour Norsepan. You can improve their physical function and improve the quality of life. So you have to select the patient really good. You can't be a doctor to say, I don't prescribe opioids. That's it. No. So for us, we assess every patient differently. We've got to individualize our treatment. So for older patient, 80 years old, medical condition, a lot of medical condition, not a candidate for surgery, 5 microgram of Norsepan patch of Plexia, immediate release, 50 milligram 1 or twice a day, and helps them, improve their quality of life. There's no reason why not to continue that.
Okay, thanks. The next one is about radio frequency ablation, and if people can have that done more than once.
Okay, so one thing about radio frequency ablation, there's 2 types of radio frequency treatment. One type is what we call conventional radio frequency ablation. We actually zap the nerve at 80 to 85 degrees to burn the nerve so that the nerve is thermocoagulated, so they can't send a pain signal. This is usually for facet joint pain. There's another radio frequency treatment, what we call pulse radio frequency treatment, that we pulse the nerve root or bigger nerve, that we don't want to burn them, because if we burn the bigger nerve, like sciatic nerve or nerve root, you can cause a lot of weakness, a lot of pain. So we do pulse radio frequency at 42 degrees. That's the 2 groups of radio frequency treatment. So radio frequency ablation, so we burn the nerve, stop the pain signal transmission, but within 6 to 12 months, every day the nerve will regrow. And sometimes it depends on how much of the nerve that you burn. Within 6 months or 12 months, when the nerve regrow, the pain pathway redevelop, and a patient can experience the pain again. So we can repeat the radio frequency ablation, but we want to do it at least only twice a year, every 6 months. So once or twice a year, when the pain comes back after 6 months, we can repeat the procedure. And the risk is very, very minimal, because by burning the nerve again, it doesn't cause other complication. So yes, the short answer, yes, we can repeat it, but we don't want to repeat it less than 5 months. We want to usually repeat 6 to 12 months.
Okay, and do people eventually get like long-term pain relief from that, or is it something that they need to keep having all the time?
So if we get pain relief for 6 months or 12 months, we tell the patient, in the next 6 months, your pain will be good. Now we're going to look at how long-term management, the short-term management to get your pain down. The long-term management is to improve your physical function and improve your quality of life. That's why we said this procedure, the outcome doesn't last long. So in the next 6 months, we need you to start doing some, more walking, more exercises, more core exercises, more back exercises, so that we can stabilize your spine and not, further aggravate your degeneration. So by telling the patient to exercise, to have all these lifestyle modification, being active, going out, doing things, we felt that they can move their joint, make their joint a bit more mobile, improve their muscle activity, then they can get a bit more long-term benefits and slow down the rapid degeneration when you're in 70 and 80 years old.
Mm-hmm. And then just while we're still on the topic of RFA, there's a question here about the success rate for the knee, the genicular nerve RFA, the knee pain.
Yeah. So we get about 80% of good outcome for facet joint RFA. Knee, it's a bit more complex because knee is a bigger joint, facet joint is a small joint, and we know very well when from cadaveric dissection, each facet joint is supplied by two small medial branch. They're very, very standardized, and we know 95% of all the population, the facet joint is supplied by two standard nerves. So if we do that procedure, we know that we're going to have 80% of a success rate. But for knee, it's a bigger joint, the three compartment, lateral compartment, medial compartment, and patellofemoral compartment. And knee is supplied by a lot of different nerves. So it's impossible for us to block all 100% of nerve that goes into the knee. We can only block about 3 to 5 nerves. 3 of them are genicular nerves, which I show you. And some of the, the other 2 nerves that we block are usually the suprapatellar, infrapatellar nerve. And we can do radiofrequency ablation based on where the knee pain is. So if we do radiofrequency ablation on 4 or 5 of the small nerves, we can achieve about 60% of outcome. Doesn't mean that their pain reduction will be 100%. They'll probably get 50 to 80% of pain reduction because there's still some nerve fibers that we weren't able to block, because knees, it's a big joint. It's supplied by innervated by a lot of different nerves.
Mm-hmm. There's a really good question here about complex chronic pain patients often having lots of financial stress as well, and if any of these sort of higher level procedures are offered in public services. It doesn't seem to be something that patients who go to public pain clinics get offered. Yeah,
unfortunately, in Australia, in New South Wales or in Sydney, in general population, only about 50% of patients, the population has private health fund. So if you are a complex pain patient who doesn't have private health insurance, we can also see them in the pain clinic compared to public pain clinic, which the waiting list is between 6 to 12 months. But if you go to Westmead, Nepean, or Liverpool Hospital, your waiting period to see a pain specialist is more than 12 months. So we can see this patient, to manage their pain in the clinic. They do not need, they need to have a Medicare card, and a lot of private pain clinic within Sydney can, offer some non-interventional management, with just a little bit of gap on your consultation. But if the patient would like to have some of this intervention, there are a few public pain services in Sydney: Royal North Shore Hospital, Prince of Wales Public Hospital, RPA Hospital, Nepean Hospital. They do offer this kind of intervention. Unfortunately, St. George Hospital, St. Vincent's Public, Westmead Public, they don't offer this kind of intervention. Concord doesn't offer this kind of intervention. There's only Royal North Shore, RPA, Prince of Wales Public, and Nepean, which is, and also some neurosurgeon in Liverpool Pain Clinic does offer this sort of intervention.
Okay. There's a question here about complex regional pain syndrome and whether that's a clinical diagnosis or if you need to do any investigations to prove that, I guess.
Yeah. So complex regional pain syndrome is 99% a clinical diagnosis. So sometimes a patient presents to you after 2 years, sometimes the swelling and redness has disappeared. And those are what we call chronic. So to actually diagnose a CRPS or complex renal pain syndrome, we need to fulfill a diagnostic criteria, what we call a Budapest criteria. They have to have pain, more than 3 to 6 months, chronic pain, which is, a bit more than what they're inciting injury. They might have just a small injury, like what I say, a bit of sprain in the ankle, but then the pain becomes so bad, 10 out of 10. And they have to have signs of swelling, and a bit what we call vasomotor and pseudomotor sign and symptoms. Means increase the temperature or reduce temperature when you feel the ankle on the arm, increase sweating or reduce sweating, sometimes change of skin color, red, pale, or sometimes purplish color, or sometimes if it's more than 6 months, the nail changes, or also what we call skin changes too. So
okay,
it is definitely a clinical diagnosis.
Yeah.
Some orthopedic surgeon will refer the patient for a bone scan, or what we call a 3-phase bone scan, to help with diagnosis, but we really don't need that. It's a clinical diagnosis. On 3-phase bone scan, you can see in the delay phase, there is what we call accumulation of the contrast in the hand or the ankle where the CRPS is. But you don't need that scan to diagnose CRPS.
Okay. There's a quite relevant question, I think, to GPs here about basically patients who respond to like CT-guided cortisone local anesthetic injection into, lumbar back pain or facet joint pain, and then how often they can go and have that done, how many times is helpful, I guess.
So again, there's no definite answer for that. Short answer, 2 times a year. Okay, but depends on the patient. If you have an old lady in a 60 years old age group, who is not very active, then that they're more higher risk to develop osteoporosis because they are postmenopausal, they have probably low calcium intake and low calcium, and they have more risk of develop osteoporosis. And also patients who had some what we call inflammatory arthropathy, like rheumatoid arthropathy, has been on oral steroids many years. These are the patients, then you want to reduce the cortisone injection to less than 2 a year. So, but if the patient is responding with cortisone injection, I think the next step for this patient for definite treatment will be a radiofrequency ablation without needing to give the patient any chemical like cortisone. Okay.
Would you have the same advice for things like shoulder joint injection, knee joint injection in terms of like twice a year or so?
Yeah. Again, depends on the patient. If a patient is like, in a 55 to 75 age group, a lot of surgeon, knee surgeon thinks that this is a good age group to have a knee replacement. So you might actually only do 1 or 2 knee injection. Then, you want to refer to the knee surgeon or the public health system to put them on a waiting list for knee replacement. But if they're on a waiting list for 12 months, then you can also refer them for 1 or 2 cortisone injection. But then, definitely treatment is knee replacement. But the patient is like over 75, 80 years old, that is not a candidate for knee replacement surgery, then, this patient can have ongoing 2 or 3 cortisone injection a year to see them through the end of their life.
Okay.
But if the patient responds well with cortisone injection in the knee joint, then patient is also a candidate for radiofrequency ablation.
Okay. Question here about the complications of the spinal stimulator. What sort of things would you talk to patients about?
Yeah. So as I said, this sort of therapy is not for everyone. Less than 5% of the patient population I see will have the indication or candidate for this procedure. Usually, they don't have widespread pain. They don't take a lot of opioids. They don't have a lot of psychological issue. And also, we think this patient usually have 1 or 2 spinal surgery and still has pain. So when you see all this, you exclude all these criteria, then it's only 5% of the patient population I see that's indicated. We actually tell the patient, even though this is a trial, it can be invasive. Usually we leave the electrodes for 7 to 10 days. So there's a risk of infection, bleeding, nerve injury, spinal cord injury. This range between 1 to 5,000 to 1 in 200,000. So we tell the patient about all these risks, but we tell this patient that, this risk can be managed by, we do all this procedure in theater, everything is sterile to reduce the risk of infection. We do it with very minimal sedation, we don't move. And then we actually, usually most of 80% of patients, we do an MRI to make sure that there's not a lot of scar tissue, there's enough epidural space for us to place the electrode.
Lovely. And I think we've probably got time for one more. So there's one here that's a bit of a case study, I guess. So a 60-year-old patient, 2 years post an L5 osteoporotic fracture with ongoing low back pain, can't tolerate anti-inflammatories or opiates, Panadol and Lyrica ineffective. What would you suggest next? Yeah,
so for a 60-year-old to have osteoporosis is actually quite young. So usually it's probably ladies, probably perimenopausal or postmenopausal. 60 years old, they could be on oral steroids for a long time or have a lot of cortisone injection. I think if we have to look at a CT scan, if there's a compression fracture, even though there's no Medicare rebate for what we call now vertebroplasty, I think if the fracture is more than 40%, then we can refer to the neurosurgeon or refer to intervention and radiologist to do what we call injecting cement into the vertebra to strengthen the vertebra. Because this sort of patient, when you have osteoporotic fracture, you refer to the neurosurgeon for spinal fusion. Most of the surgeon will not put screw and bolt in because the bone is so weak, and that the screws will actually move in the soft bone. Again, at the same time, you want to also refer them to endocrinologists to look at how we can improve their bone density. So, through other, zolichronic infusion, all those kind of injection to help with their osteoporosis.
Lovely. I think we're pretty much at 8:30 now. So I just want to say thank you so much. It was a really informative presentation, and I think we've all definitely got something out of that. So it was really helpful. Thanks.
Thank you very much. Dr. James Yu, Dr. Claire Stewart, thank you for your contribution to this education event.